Biologically speaking, fear is a highly specific reflex. It is a sudden, localized response tied directly to an immediate physical threat. Anxiety is different. It is a pervasive, inescapable apprehension that persists long after a threat has passed or before one even appears. And when we look at human anxiety disorders today, we find a strange statistical mismatch between the things most likely to kill us and the things we are actually terrified of. Every year, millions of people are injured or killed by modern machinery. Automobiles consistently rank among the highest causes of non-medical mortality worldwide. But biological threats, like spiders or snakes, cause a statistically negligible number of deaths in modern societies. Yet these animals remain the dominant triggers for debilitating clinical phobias. This chart illustrates the discrepancy. While phobia rates for lethal modern inventions like cars or electrical outlets sit near zero, roughly 11% of adults will suffer from a clinical phobia at some point in their lives, heavily skewed toward ancient biological threats. These intense fears are not random glitches in the human brain. They are highly conserved, evolutionary learning mechanisms working exactly as they were designed to millions of years ago. Abnormal psychological anxiety, at its core, is simply a survival system that has become miscalibrated and trapped in a behavioral feedback loop. In the early 20th century, behaviorists like John B. Watson argued that all intense human fears were mechanically learned through direct experience. Watson famously tested this in the Little Albert experiment. He took an 11-month-old infant who showed no natural fear of animals, placed a white rat in front of him, and repeatedly struck a steel bar with a hammer behind the child's head. After a few repetitions, the infant began to cry and crawl away at the mere sight of the rat. The unconditioned terror of the loud noise had successfully transferred to the previously neutral animal. But Watson's model has a fatal flaw when applied to modern clinical phobias. Most patients treated for extreme fears of heights, spiders, or snakes have never experienced a single traumatic event involving those triggers. Furthermore, toddlers routinely shock themselves on electrical outlets or burn their hands on hot stoves, yet they almost never develop lifelong, paralyzing phobias of electricity or kitchens. If acquiring a phobia required direct trauma, the distribution of our fears would match the distribution of our injuries. Basic classical conditioning cannot explain why our brains selectively latch on to specific triggers while ignoring actual repeated dangers. The missing variable in Watson's equation is biology, specifically a concept known as evolutionary preparedness. Mammalian brains are genetically primed to rapidly encode fears of phenomena that consistently killed our ancestors. We are predisposed to fear predators, darkness, and heights because those variables exerted millions of years of evolutionary pressure on human survival. In the 1980s, psychologist Susan Meinecke demonstrated exactly how these primed fears are activated without direct trauma, through observational learning. Meinecke placed a laboratory-reared monkey, which showed no baseline fear of reptiles, in a position to observe a wild-born monkey. When Meinecke introduced a snake into the environment, the wild monkey reacted with absolute panic. Watching its partners shriek and run was all it took. The laboratory monkey instantly absorbed the terror, displaying a permanent, intense fear of snakes from that single observation. But Meinecke ran a second test. This time, she blocked the lab monkey's line of sight to the snake. The lab monkey could see the wild monkey panicking, but it could not see what was causing the panic. In this scenario, the lab monkey learned absolutely nothing. To encode the fear, the observer's brain had to visually link the panic to a specific, identifiable target. This exact mechanism drives human social transmission. Children constantly scan adults to evaluate environmental safety. When an adult displays intense fear toward a spider, the observing child absorbs that reaction. Phobias do not require trauma. They are rapidly acquired the moment an ancient genetic predisposition is activated by a socially transmitted visual trigger. Acquiring a fear explains how a phobia starts, but it does not explain why that fear stubbornly persists for decades without fading. The persistence of anxiety relies on an operant conditioning loop known as avoidance learning. Consider a standard laboratory setup. A subject is placed in a test chamber and trained to press a lever every 10 seconds to avoid a scheduled electrical shock. Once the subject learns the rules of the environment, they will consistently press the lever to bypass the pain. Now, the researchers permanently disconnect the shock generator without notifying the subject. The subject, trying to stay safe, continues pressing the lever indefinitely. Because the subject never stops hitting the lever, they never allow enough time to pass to realize the shock is gone. They are effectively trapped by their own successful evasion. Human phobias operate on this exact mechanical loop. If you are terrified of spiders, running away from one provides immediate relief from your anxiety. That relief acts as negative reinforcement, rewarding the act of running away. In conditions like panic disorder or agoraphobia, this avoidance turns inward. Patients begin avoiding crowded spaces, public transit, or even leaving their homes, entirely to prevent the occurrence of their own internal panic attacks. Avoidance behaviors are the engine of anxiety. By successfully escaping the trigger, the patient never allows their brain to perform a reality check, guaranteeing the permanent survival of the phobia. To treat a severe anxiety disorder, clinical intervention must physically break that avoidance leak. The most successful treatment is systematic desensitization, or exposure therapy. The objective is to artificially block the patient's ability to flee the trigger. Therapists use graded shaping. A patient with a snake phobia starts with a cartoon, then a photograph, a video, and eventually a live animal. At each step, the patient is prevented from escaping, keeping their nervous system fully engaged. Modern technology allows clinicians to tightly control these exposure variables. Virtual reality headsets can simulate high-altitude bridges or crowded rooms, allowing patients to face their exact triggers from the safety of a medical office. This works because of a strict biological threshold. The human body cannot sustain a permanent state of panic. Stripped of the ability to escape, the sympathetic nervous system eventually exhausts itself and forces the heart rate to drop. Successful therapy does not rely on talking a patient out of their fear. It relies on physically trapping the avoidance mechanism until the body returns to its baseline. But there is a major misconception about what this clinical extinction actually achieves. Extinguishing a learned response does not erase or delete the original fear pathway in the brain. This is why an extinguished phobia can suddenly reappear months or years later, a phenomenon known as spontaneous recovery. The original blueprint for the fear is still there. The true neurological mechanism behind clinical extinction is the active construction of a completely new, localized memory pathway, one that formally declares the previously terrifying stimulus is now safe. Following therapy, the brain holds two competing predictive models. For the cure to hold, the new safety memory must be continuously reinforced in multiple environments until it reliably overrides the older, deeply entrenched fear memory. This is why simply knowing a fear is irrational never cures a phobia. Patients with severe anxiety disorders are already entirely aware that their threat response is disproportionate. Abnormal psychological loops cannot be reasoned with. They must be systematically dismantled by forcing the brain to gather inescapable new physical evidence.